Hello there, my name is Gloria Williams.
And I'm Quinton Sheppard.
And we're with the Gloucester County's Community Engagement and Public Information Department. We are truly honored and excited to share some time this evening with some very special guests. Dr. Richard S. Williams, MD, MPH, and Director of the Three Rivers Health District, and Ms. Lisa Laurier, Population Health Manager, Division of Community Health, also with the Three Rivers Health District. Thank you both so much for being here tonight.
We really do appreciate you all taking the time. We know how incredibly busy you and all of your staff have been in what seems like an eternity, but we're creeping right up on about a year now of going through this, and we just appreciate you and the information that you're able to provide and the information you've been providing so steadily along the way. And thank you for speaking with us tonight on this recorded Zoom call so that we can share some important information and updates. Let's kick things off with a brief introduction and a little bit of a discussion on exactly what the Three Rivers Health District is and how it fits under the umbrella of the statewide health district as a whole.
Okay, so the Three Rivers Health District is one of 35 health districts throughout the state of Virginia. And the health districts are the field arm of the Virginia Department of Health. The central office or the headquarters of the Virginia Department of Health is in Richmond. There are other field units that deal with anything from water quality to shellfish industry, but the main field units of the VDH are the health districts. And the health district mission is public health. It's environmental health. We have clinical activities that we do. We have our WIC program for infants and children and women. And we have our Ryan White program in Three Rivers, and a host of other things that we do, normally nursing home screenings and so on and so forth. And one of our core responsibilities is under the emergency management umbrella is response to any sort of contingency, whether it's natural disaster or in this case, a pandemic, which is what we're in the middle of now.
So I think it's safe to say that you all were beyond busy to begin with, and now with this pandemic on top of you, it's just been a crazy past year. And again, we just really appreciate all that y'all are doing.
Yeah, I don't think this pathogen is so capable and so contagious. And it's stealthy. I mean, it has features, it can activate your own immune system against you. It might be totally asymptomatic in one sector of the population and lethal in others, like older folks and so on and so forth. So I don't think this sort of a pathogen was in anybody's planning playbook, if you will. All of our annual exercises with vaccination programs and so on and so forth are aimed at a flu-like scenario, and this is much light years more difficult and challenging than flu. And it's been steady over the past year. It didn't really show a seasonal variation like flu did. So we had to ramp up our community mitigation efforts with contact tracing and case investigation. Very early on, we had to, ramp up our epidemiology efforts, tracking the data and tracking this virus as it expressed itself in the population. Our executive order compliance, effort had to ramp up, as well as many other things, public communication, education, and we had to learn as we went. Right, it was a brand new pathogen. Nobody ever saw it before a year ago, or a little over a year ago, when it emerged from, we think, from China. So it's been a steep learning curve and a very, very high operations tempo. And now with the vaccine program in the way that's progressing, it's I would say almost exponentially higher. So it is a very, very challenging scenario we find ourselves in.
Well, thank you for that. And we do know that a lot of things are changing by the minute, by the day, by the hour. Maybe if you could talk to us a little bit about the new statewide registration system, how it's going, how integration is going, and what that means for a typical citizen.
Yeah, when we were ramping up, or when we were leading up to receiving vaccines, these are all the vaccines, whether it's Moderna or Pfizer, Johnson & Johnson, Oxford, AstraZeneca, none of these things existed a year ago. So they were designed, they were developed, they were manufactured in record time. They went through all phases of clinical trials in record time. So we didn't really know what we were going to get until the November, really December timeframe, and we didn't really understand it well until it arrived on our doorstep, and we were able to see for ourselves the requirements to use, especially the messenger RNA vaccines, the Moderna and the Pfizer. So we really had to adapt our vaccine core emergency response, which is flu, to this very, very complex vaccine that both Moderna and Pfizer produced. At the same time, we started off with from the Advisory Committee on Immunization Practices of the CDC, we started off with a prioritization of folks in phases. Phase 1A was the healthcare providers. Phase 1B started off 75 and older and some frontline workers. That was expanded by the Secretary Azar in the Department of Health and Human Services just a little over a month ago to include a whole lot more people. It more than doubled the pool of eligible folks. So when we started this, and again, we had to design all this de novo, and each health district had to meet the need immediately. So we all did very similar sorts of things, but not identical with regard to developing sign-up lists and so on and so forth. Phase 1A, we had plenty of vaccine. We were able to learn to use the vaccine. We had a target population, which was not huge, healthcare workers. So that phase went pretty well. And most of us were done with that within about 4 weeks or maybe a little bit longer. But as soon as phase B started, and then we had to figure out, how we were going to record the people, how we were going to reach out and find out who wants the vaccine, and at the same time looking at essential frontline workers in industry and finding out where those employers were and creating ways to reach out to them. So what we ended up with was a methodology where people could contact us and pre-register for a vaccine. And almost every district had that capability. When phase 1B opened up, about the same time, we entered a severe vaccine shortage at the national level. So that created a perfect storm of delay that we're still in. So the lists of people waiting grew by the thousands, and in some cases, the tens of thousands. And it became pretty obvious to the central office that it would be much better if we had one way for all Virginians to sign up for a vaccine that was common across all the health districts. So the call center was an attempt, and is an attempt to provide a single point of contact for COVID-related questions, for opportunities to sign up for vaccine, to be led through the vaccine pre-registration process. And eventually the plan is to leverage that to lead to appointments for vaccination. Some of them may be centrally modulated, some at the local health district, but that was the idea. At the local level, we're not very well staffed. We certainly were in no way staffed to deal with a pandemic of this duration and a pathogen of this ability. And we've had to ramp up with hiring contract folks in various roles. But if the burden of calls and pre-registration and even appointments for vaccines, if that could be done centrally, then it frees up the health districts to do community coordination and organizing vaccination events and setting up the infrastructure. We really, to distribute this vaccine, we not only have to have our own health department, points of distribution, but we also have to coordinate with all of our clinical partners. In Three Rivers, we have 3 different hospitals representing 3 different healthcare systems. We have pharmacies, we have private medical practices, we have free clinics, we have federally qualified healthcare centers. And all of those folks are capable of delivering vaccines, and many of them are signed up and approved by the CDC to do so. So to leverage all of that vaccination capability, we have to work together, collaborate, organize all that, and bring our maximum potential to bear. And having the central call center relieve us of some of those sorts of responsibilities has the potential to help us a great deal to pay more attention to that sort of stuff, which actually leads directly to getting shots in people's arms.
That's great news. Definitely a step in the right direction. So what, if any, changes can people expect over the coming weeks regarding vaccine dissemination?
You know, we're still in the throes of a very high grade vaccine shortage. I don't know the ins and outs at the federal level, but I imagine that we are across the country. We're pretty much depending on the real-time manufacturing throughput of both Moderna and Pfizer. They will hopefully soon be joined by Johnson & Johnson, but I don't think there's a great reservoir of J&J vaccines that could be disseminated either. I've heard several million to begin with, followed by more after. But I think that the vaccine shortage will be resolved over time, but it'll take time to do it. I don't know. And so I think the ramp up of available vaccine, it won't happen all at one time. It's going to be gradual. So that's very disappointing to all of us. If somebody told me that I'm eligible for vaccination, I would take it for granted that if I'm eligible, then the capability to vaccinate me must exist. Okay, that's a logical thing to think. But in point of fact, the capability probably does, but the vaccine is not there. So we're using this time, you know, we're getting only in Three Rivers, only about 20 to 25, less than 25% of the vaccine weekly that we're capable of delivering, okay? So we're using this time to organize ourselves, to leverage the strength of our clinical partners, to set up infrastructure that once we do get vaccine, we can ramp up to scale and get through this as fast as we possibly can. So that's what we're doing with this. The Johnson & Johnson vaccine is a single dose vaccine. The Pfizer and Moderna have 2 doses. If you think about that, if I deliver 100 shots today, and that's my capability, well, 28 days from now, I have to deliver 100 shots. It's more like capability is more like 500 plus, right, for each entity. But it really encumbers your vaccine capability with that second shot, 21 or 28 days whenever you encounter it. So it really cuts the speed of your effort in half, having to do 2 shots. 1 shot with J&J, it's kind of like flu. It's not as delicate as the Moderna and the Pfizer. If you shake a vial of Moderna, or you drop it, or you drop a vial of Pfizer, it breaks the mRNA, and it really renders the vaccine unusable. If there are temperature violations, then the vaccine becomes unusable, and the temperature requirements are strict. J&J, much easier. In a single shot, we can move much faster. So we're all looking forward to getting that.
Well, thank you for that. It's really helpful to just understand all the pieces that are working and how involved and that you are at every level. And I'm glad to hear with the call center and the changes that are coming online, that the health departments are able to continue doing what they do best, which is working in the communities. And you've done such an incredible job, and we appreciate it so much. So many people are operating under the assumption that once they become fully vaccinated, they can return immediately to normal life. No masks, maybe social distancing. What message do you have what net message needs to reach those operating under that opinion?
Yeah, and this is a very strong message. So this virus is very adaptable, and it's genetically drifting all the time. Coronaviruses tend to do that, and this is no exception. That combined with the fact that we really don't have very much experience at all with these vaccines at the population level. There's a lot not known about them. We know that they reduce serious disease. They're capable of reducing serious disease to mild disease. We're not sure if you're vaccinated, if you can't be reinfected. If you are, we think there's evidence emerging that if you're reinfected after or infected after vaccination, that the viral load is much lower and you may not be able to transmit the disease as well. But there's pretty good evidence that you can get infected again after vaccine, or at least some people can. Some people may be protected fully, but we can't count on that. If you couple that with the fact that this virus is genetically drifting, and some of the most critical mutations are at the spike protein. The spike protein is what the virus uses to attach to the cells in our respiratory system to invade our bodies. So if that spike protein, if the genetics controlling that spike protein mutate and the spike protein changes, then our vaccines, which are engineered to target that spike protein, may be less effective. That's the virus's way of evading our defensive measures. The other thing is these viruses, these new variants tend to be more infectious. So they potentially defeat our countermeasures on a number of ways. They might defeat social distancing. They might, and that make that, infection is based on the amount of viruses you inhale, right? So the way you inhale less viruses is there are three things: distance, time, and a barrier to inhaling or exhaling virus. That's the social distancing, 6 feet or more, the time, 15 minutes or less in the presence of somebody exhaling COVID. And then the mask does filter out viral particles. So all of those things work together to limit the dose if you do happen to encounter a COVID positive person. Well, these viruses are evolving and genetically drifting to potentially defeat those things, as well as change the spike protein, which makes the vaccine, the antibodies that the vaccines develop, not as effective. Now, there are other parts of the immune system that are also active here, T cells and other things that are good. So the vaccines will undoubtedly remain at least somewhat effective, but we can't count on complete effectiveness. So what that means is after you get vaccinated, it's especially with high community transmission levels, and we're still in high community transmission levels, it's not a good idea at all to stop defensive measures. You still need to do exactly what you were doing before. And we'll know when we can come out of masks, and we'll know when we can, limit social distancing, when the virus loads, when the prevalence of the disease drops to very, very low levels across the country. That's when public health authorities will start telling us, hey, we're kind of getting ahead of this thing, and it's okay to relax some of your defensive measures, but not until then.
And you spoke a little bit about this, but we're seeing on the news and announcements that case numbers are declining pretty dramatically, locally and nationally. Do you feel like you can comfortably say we're finally on the downward slope of this virus?
I would say that's very, very encouraging. It is unusual for a pathogen that's transmitted via respiratory means like flu. Flu season lasts way beyond January and February. It lasts into March and even into April. So this virus we're seeing drops in prevalence across the country, really during the time when respiratory viruses shouldn't be doing that. So that's very encouraging. And that may be due to enhanced protective measures. People are paying more attention. It may be due to some population immunity. Probably well over 100 million people have been exposed to this thing, either through vaccine or through infection. A lot of infections are asymptomatic, as you know. So we may be getting some regional population immunity. So the fact that the case numbers are dropping is extremely encouraging. The unknown in this are the new variants from South Africa, United Kingdom, and Brazil that we've all heard about. And just a couple of days ago, there was a study published that found 7 other new variants that are domestic to the United States that have the same kind of mutation at their spike protein. Okay, so this is probably happening at a far higher and greater rate and extent than we even know at this point, and we'll discover when our genetic sequencing capability gets a lot better. But those are the unknowns. So if the new variants are capable of causing resurgence of viral infections like happened in the United Kingdom, then we might see that. But other than that, the cases trending down is very highly encouraging.
Wonderful to hear, for sure. Well, so a lot of people, many people are concerned about children, and obviously for obvious reasons, and schools are a hot topic. And but some people are interested in information about when children will be able to receive vaccines. When can we expect to see a vaccine for younger children? And if you could just talk about children and schools in general, that would be really, really appreciated.
Sure. There is thought to be some built-in advantage for kids, especially younger children in the early elementary grades and toddlers, and that they don't have as many of the receptors in their respiratory system that actually can serve as a target for this virus as adults do. So if they do get infected, they tend to be much less viral load and less severe, and they're not as capable of transmitting the disease as adults and older kids are. You lose that advantage when you get out of the early into the mid, elementary grades and on into middle school and all that. You start looking more like an adult at that point. But the little kids especially do have some built-in advantages with regard to less severe. They certainly can get infected. There's no doubt about that. And there have been some cases of multi-system inflammatory syndrome in children related to COVID. But that is the exception to the rule. There are, and with regard to the schools, we've shown that with adequate social distancing and masking and attention to those sorts of details, hygiene and facility, keeping a healthy facility and doing early contact tracing, we've shown that we can keep kids in school, even in high community transmission levels with those protections intact. So that's been very encouraging. With regard to the vaccine, the target population to begin with was those people that emerged very quickly as being the most vulnerable. That's adults, especially older adults. It was very obvious very quickly that older adults and people with underlying medical conditions suffered the most from this virus. Plus others, people of color tend to also have hospitalization and mortality rates several times that of the white population. So that's where the early investment went. But I think some of the companies now are conducting phased clinical trials in children. So I think that possibly by after the summer into next fall and winter, then some of those phase 3 clinical trials in children may have been conducted for safety and efficacy. We might actually see COVID-19 vaccination available for children sometime in the fall timeframe and into the winter of next year.
That's good to know. And one final question we had was about, we're in a pretty rural area. Not everybody has access to, traditional means of getting information through the internet or through your website and that type of thing. What's the health department doing to reach those in underserved communities and also those populations that may not be able to reach you otherwise.
Yeah, we recognize that dynamic immediately. The CDC actually created an internet-based email-dependent appointment system that they rolled out concurrent with the vaccine. It's called the Vaccine Administration Management System. And that did not work for us in rural Virginia almost immediately. So we went straight to paper with paper records and phone calls to manage our vaccination appointments and our administration and the data entry into the immunization information system. We set up a means where most people can get access to a telephone. So in Three Rivers, we had excellent support from our local jurisdictions, from Gloucester County, who set up a call center for us. And then the jurisdictions in the Northern Neck collaborated on a call center in the Northern Neck. And so people could call that call center and the operators would walk them through. If they couldn't do it themselves, the operators would help walk them through a survey to take all the information we needed and record them for pre-registration for a vaccine appointment. We started off doing that with our local health department office personnel, and then shifted to the call center. And we also leveraged a vaccine eligibility tool that took personal information early on, the Sheppard tool, you might have heard of that. We also captured that data and added it to our list. So we've had the whole time the means to do it online or get help walking through it. And that capability perpetuates into the central call center.
Excellent. Well, you have covered so much information and we really just appreciate it. And I don't know if there's, Quinton, do you have any other questions? I feel like all of my questions were certainly answered. We could sit here all night, but we know that you don't you have a lot to do.
Is there anything, Dr. Williams or Lisa, that you'd like to relay to our residents that we haven't covered this evening?
I can tell you from my perspective, I entered the workforce in 1975 in the Air Force, United States Air Force. And I had a 27-year Air Force career followed by 20 years in the National Aeronautics and Space Administration. Started off as a surgeon. I'm a fellow of the American College of Surgeons, and mid-career, after a couple of contingencies, armed conflicts in the military, I switched to, I'm also a pilot, so I switched to aerospace medicine, and that really qualified me to do the job I'm in. But in my career, I've been in a position of medical leadership in every infectious disease event we had. From anthrax in Washington, D.C., we had anthrax in the headquarters NASA building. I was chief medical officer of NASA then. H1N1, Ebola, Zika, SARS-1, MERS, all of those things. I had global responsibilities during those pandemics. Two armed conflicts that I was personally involved in, 5 hurricanes, loss of Space Shuttle Columbia, and all of my experiences in fairly high risk situations as a pilot and operating as a surgeon. Okay. And after all of that, I can tell you that this is absolutely the hardest thing I've ever done. This is a very, very demanding, high operations tempo, almost a 24-hour-a-day job. It's been that way for a long time. It has intensified with the rollout of the vaccine. And I would just ask everybody to be patient as they can. Nobody wants to get this shot out there and get ahead of this thing as much as we do in the healthcare industry. And we're going to work as hard as we can to make it happen. Just everybody be as understanding as you can and as patient. And we will get to everybody that wants a shot, I'm confident, within the next several months, probably by summer. I think Dr. Fauci probably is correct. And the folks in the current administration are saying summertime is a target for having vaccine for everybody. And I think it'll take that long, but we're going to get there.
Well, thank you for that. And we're so glad that you're here in our district. And just on behalf of Gloucester County, thank you so much. And we're here to support you in whatever way that we can. And we're just very glad to have you and your leadership. So again, to you and to Lisa and to your entire team, just again, thank you for your time, your leadership, your service, and your willingness to share it with our communities. We are safer and healthier because of the incredibly important work that you, our frontline workers, and the many individuals and organizations working together to power us through this crisis. So thank you for that.
Well, on behalf of all the employees of the Three Rivers Health District, and they're all dedicated, and they're all working really hard, and they're excellent. And so on behalf of all the employees of Three Rivers and the VDH, it's our honor to be here. It's our honor to serve, and thank you very much for the opportunity to talk tonight.
And just wanted to let everybody know that all of the information we discussed this evening, plus up to the minute updates, can be found on the Three Rivers Health District website, which is www.vdh.virginia.gov/3-rivers. Also, Gloucester County tries to keep updated information on our website at www.gloucesterva.info. And on our Facebook page by searching for Gloucester County Government. Again, thank you, Dr. Williams. Thank you, Lisa. We're definitely, I think, in the best hands that we could ask for. And we just ask everybody to remain vigilant, stay safe, wash your hands, and wear a mask. Hope everybody has a great evening. Thank you.
Thank you all.
Thank you.